So using the chat box, Alejandro Martinez, can you just tell us where you're from and which residence you are? You're always there, so your name is. I recognize your name. I think you're mostly present in every session. Using the chat box, can you just tell us till we're waiting for Dr. Afifa to start? Or you guys can give feedback. I mean, we never have had any feedback from you guys. Is there anything you like to do to this session? Maybe add a little things up so we can use this time today until Dr. Afifa join. We can have feedback. We have Anam Fatma. Anam, Dr. Anam is from Lahore General Hospital from Pakistan. And I'm using the chat box. Can you tell us if you want to house the session? Do you want to change it, or we should continue the way it is? And is it helping you or not?
Assalamu alaikum, Saad. How are you? Assalamu alaikum, everyone. Sorry,
we just wait.
Yeah.
Assalamualaikum. We're just waiting for Afifa. She's having some problem with Zooms, so she's using another laptop. So, I'm just talking.
If there is a delay, do you want to start with Professor Deopujari and he can guide us, and then we can go back onto anatomy after that? Do it the other way.
Salman, unfortunately, today I am a little delayed. I'm still traveling to work. So I'm very happy to be with you, but I won't be able to share screen. I'm trying to see if I can join my laptop to the tether to the phone, but I also need a little time.
Okay, sure, no problem.
So we're just talking to the participants, and Dr. Anam, I think she's from Lahore General Hospital, recently cleared her boards, and she's saying that the sessions have really helped her and that we should continue them. So yes, at last we have Dr. Afifa with us. Thank you, Dr. Afifa. We can see your screen. I think since we're already late, I would like you to start. And please, Afifa, can you make sure that you use your pointer? Can you please move your pointer, because Afifa, we can hear you.
Afifa, can you start, please? Thank you.
Thank you, Dr. Martinez, for your introduction. Yeah, Dr. Martinez is from Venezuela, and is, I think, currently in Peru. Dr. Afifa, if you can hear us, please start your presentation.
Yes, sir, we're just starting.
And can you make sure you use your pointer and that it's moving?
Thank you. Good morning, everyone. Can you hear me?
Yes, Dr. Afifa, you're audible, but speak up a little. It will be better.
Okay. Okay. So sorry for the delay. Today, the topic of our discussion would be surgical approaches to the third ventricle. And we would be first initially going through a brief review of the anatomy of the third ventricle, and then we'd be proceeding towards the surgical approaches. So as we all know that the third ventricle is basically a narrow funnel-shaped structure that lies in the center of the brain. It lies below the corpus callosum and the body of the lateral ventricles, between the two thalami on the either side and the walls of the hypothalamus, and above the pituitary and the midbrain. It communicates with the two lateral ventricles at its anterior superior margin via a foramen called the foramen of Monro, and posteriorly it communicates with the fourth ventricle via the aqueduct of Sylvius. As we can see here, this is basically the unilocular midline funnel-shaped cavity of the third ventricle that we can appreciate. This is the roof of the third ventricle. Here is the posterior wall of the third ventricle. This is the floor of the third ventricle. This is the anterior wall of the third ventricle. So basically, the third ventricle has four walls, that is the anterior wall, the posterior wall, the two lateral walls that are present on the either side, and a roof and a floor that we can appreciate. Subsequently, we'll be discussing what what are the constituents of these structures. So here, this picture clearly reflects basically all the relationships of the anatomical relationships of the body of the third ventricle. So the roof of the third ventricle basically is a tri-layered structure. It has a neural layer, that is the topmost layer, which is formed by the body of the fornix. Then we have the two layers of the telechoroidea, where there are thin membranes, and in between which are present the velum interpositum, which is a space. And the space houses two major vascular structures, which are the internal cerebral veins and the medial posterior choroidal arteries. Then anteriorly, starting from inferior to superior, we have forming the anterior wall of the third ventricle. We have the optic chiasm. Then we have the optic recess. Then lamina terminalis, which we can see here in the color highlighted red, which is a thin layer of gray matter and a thin layer of gray matter with the pia mater, and that is basically connecting the superior aspect of the optic chiasm and goes on to merge with the rostrum of the corpus callosum superiorly. Slightly posterior to it, we have the anterior commissure, and then slightly posterior to the anterior commissure, we have the foramen of Monro, which is basically the communication between the lateral ventricles and the third ventricle. Then coming to the floor of the third ventricle, starting from anterior to posterior, we have the optic chiasm, then we have the infundibulum and the tuber cinereum. We have the infundibular recess. We have the two rounded structures, which are called as the mammillary bodies, and the posterior perforated substance, which is basically the continuation. And then in the posterior aspect, we have the aqueduct of Sylvius, which is forming the caudal most or the posterior most edge of the floor of the third ventricle. Then coming on the lateral walls, so the lateral walls are basically formed by the two thalami and the hypothalamus, they are separated in between with the hypothalamic sulcus, which is going to be separating the two structures. This is the massa intermedia, which is the connection between the two thalami. Then we have the posterior wall of the third ventricle. So the posterior wall of the third ventricle, from the superior to inferior aspect, we basically have the suprapineal recess that is present. Then we have the habenular commissure. Then we have the pineal gland and its recess that is present. We have the inferiorly we have the posterior commissure, and then it is communicating downwards with the aqueduct of Sylvius. So here, this is basically the brief review of the structures that are forming the anterior, posterior, and the roof and the floors of the third ventricle. Again, in this picture, we can appreciate that, as we discussed on earlier, that this is the roof of the third ventricle formed by the body of the fornix, which is curving around anteriorly into the columns of the fornix, forming the anterior margin of the foramen of Monro, which is a communication between the two ventricles, the lateral ventricles and the third ventricular cavity. So this is your third ventricular cavity that we can appreciate here. This is the layer of the lamina terminalis. This is the optic chiasm that we can see. In the floor, we can appreciate the two rounded structures, which are the mammillary bodies. Here we can also see the indentation of the massa intermedia, which is the connection between the two thalami. And posteriorly, we can see the pineal gland and its recess, superiorly habenular commissure, and inferiorly the posterior commissure present. Also, in the posterior aspect of the third ventricle, in the posterior wall of the third ventricle, we can actually see the confluence of a large vein, which is called as the vein of Galen, which is basically formed by the two internal cerebral veins, as well as the basal vein of Rosenthal. So this is basically again a revision of the same slide. The roof forms of the third ventricle is formed by the 5-layer structures. That is the fornices, which is the neural layer, the superior layer of the telechoroidea, the inferior layer of the telechoroidea, and in between which we have the vascular space, which is known as the velum interpositum, and the choroid plexus, which is basically arising from the inferior most layer of the telechoroidea. So in this picture also we can appreciate the corpus callosum is basically lying superior to the fornix. Then we have the fornix, which is forming the roof. Then we have the potential space between the two layers of the telechoroidea, which we can see here highlighted as red. And then from the inferiormost layer, there is arising the choroidal plexus. And on the lateral side, there are two thelemi that are present, and anterior to which there is the presence of the chordate nucleus. So again, floor is consisting of the optic chiasm, the infundibular recess, the tuber cinerarium, and the rounded bodies of mammillary bodies. Then anterior wall, like we discussed, with the foramen of Monro, anterior commissure, laminar terminalis, the optic recess, and the optic chiasm in the superior to inferior manner. Posteriorly, again, a brief revision, the suprapineal recess, then the habeneural commissure, pineal gland with its recess, then posterior commissure, and the Sylvian duct. And the laterally, we have the two thalami on the either side and the hypothalamus lying inferiorly, and they're separated in between by the hypothalamic groove that is present. So, a brief and vascular anatomical review. In the lateral ventricle, we know that the medial and the lateral groups of veins, they actually converge at the level of the foramen of Monro to basically form the internal cerebral veins. And the main medial vein is the septal vein, which crosses the septum pellucidum and the fornix. The lateral veins include the caudate veins, which run from the posterolateral to the anteromedial aspect to cross the caudate nucleus and the thalamus and the thalamostriate vein. The thalamostriate vein is actually located in the body of the lateral ventricle, and it runs in the striothalamic sulcus located between the caudate and the thalamus. So the thalamostriate vein is basically located far most laterally, and it actually curves around the posterior margin of the foramen of Monro, which we're going to see in the coming pictures as well. At the posterior margin of the foramen, like I discussed earlier, the thalamostriate vein curves medially around the anterior tubercle of the thalamus to actually form the internal cerebral vein. And this U-shaped junction of the two veins is basically termed as the venous angle. So here we can appreciate the venous anatomy. So this is the roof of the third ventricle. In between the layers of the fornix, we have the potential space called, in between the two layers of the telechoroidea, we have the potential space called the velum interpositum, and that is housing the two internal cerebral veins that we were talking about. And we can see here in the septum pellucidum, this is the anterior septal vein that is running anteriorly. We have the posterior septal vein, which is running posteriorly. And superiorly, we have the corpus callosum, and this is the foramen of Monro. So the thalamostriate vein actually curves around on the posterior edge and basically goes on far lateral. That is how that's its course, basically. This is a coronal view, and from anterior to posterior, we can appreciate the two olfactory nerves that are present. This is the gara rectus that is present. There are two optic nerves. They're confluencing together at the level of the optic chiasm. Then they're dividing into the optic tracts. We can appreciate the laminar terminalis, which is a communication, as we discussed earlier, a thin layer of fire matter and gray matter, extending all the way from the superior aspect of the optic chiasm and converging with the rostrum of the corpus callosum. This is the foramen of Monro if you're going slight posteriorly, and this is the end column of the fornix, which is forming the anterior wall of the third ventricle, which we can appreciate here. And laterally, we can see that the thalami are present and they're forming the lateral wall of the third ventricle, and slightly anterior to them, we have the caudate nucleus that is present. So now, coming to the surgical approaches. So the surgical approaches of the third ventricle can actually be divided into the anterior approaches, we can have the posterior approaches, and we have the lateral approaches. So the anterior approaches are basically, again, further divided. We have anterior transcallosal approach, which is obviously, as the name is indicating, through the corpus callosum. Then we have anterior transcortical approach, which is through the cortex. Then we have subfrontal or approaches that are basically further subdivided into the approach via the laminar terminalis or incising the laminar terminalis. Then we can have optico-carotid via the transfrontal or the transsphenoidal region, and then we can have an axis via the subchiasmatic region that is basically below the optic chiasm. Posteriorly, we can have the access via the posterior transcallosal approach, again via opening the corpus callosum. Then we have posteriorly transcortical approach, and occipito-transtentorial, which is supratentorial approach, and then infratentorial supracerebellar approach. So these are basically all the approaches, and alongside with that, we have an endoscopic approach to the third ventricle as well. So we can like classify them into lateral, anterior, and posterior. Laterally, we can also access it via the lateral temporal and posterior frontotemporal approach. So now we would be reviewing all of these approaches one by one. So first we have the transcallosal approach. The anterior transcallosal approach is actually the most commonly used approach for access to the third ventricle, and is considered adequate for the lesions that are extending to or posterior to the level of foramen of Monro. Lesions that lie anterior to the foramen of Monro and inferior in the third ventricle, they might not as readily be accessible by this particular route. So, and this route and this approach is actually directed through the corpus callosum and is considered suitable for reaching lesions located within the frontal horn and the body of the lateral ventricle and in the anterior superior part of the third ventricle. So here we have a picture which would be discussing in the forthcoming slides. So in the anterior transcallosal approach, the patient is actually positioned supine with the sagittal suture lying in the vertical plane, and the head is slightly elevated up to 20 to 30 degrees. Alternative position could be that the patient can lie in the lateral position with the right side down, so that the gravity will help in retracting the medial surface of the right cerebral hemisphere away from the right side of the fox, so that it's easier to open and access the corpus callosum. A right frontal horseshoe-shaped incision or a bicornal S or S-shaped skin incision can be utilized, and a right frontal bone flap is basically used, extending to the lateral edge of the sagittal sinus on the opposite side, and it's located, and the craniotomy is basically located 2/3 in front of the coronal suture and 1/3 behind it, which we can see in this slide. So in the inset, we can see that the incision is basically a horseshoe-shaped incision, and this is the dotted line actually marks your craniotomy. So this is a frontal craniotomy that is present, and that we actually make for the anterior transcallosal approach. And the lateral margin is basically the edge of the superior sagittal sinus, and incision is the craniotomy lies 2/3 anterior to the coronal suture and 1/3 behind it. Then what we do is basically, okay, we are going to access, and we're going to see the choroidal arachnoid membrane anteriorly, and we're going to incise that open. In the anterior aspect of the coronal suture, basically there are very few bridging veins that drain into the superior sagittal sinus, so it's easier to maintain the control from there. And then we can basically separate the two cingulate gyri that are actually facing each other from both the cerebral hemispheres and create a space, and then subsequently access the and appreciate the corpus callosum and subsequently access the third ventricle. Yeah. So like we discussed here, that the arachnoid membrane, which is encountered deep to the free edge of the fox, is actually opened to expose the corpus callosum and the anterior cerebral arteries. The right and the left cingulate gyri, which are actually facing each other, they are separated to expose the corpus callosum and the pericallosal arteries. The part of the corpus callosum that is actually lying above the foramen of Monro is actually split in the midline, and the incision is around 2 centimeters in length, to provide an access to both the cavities of the lateral ventricle. And then further on, we can also utilize the image guidance as well in order to localize the exact point where the foramen of Monro is located, and we can just give an incision right above that in order to gain access to the cavity of the lateral ventricles. And then from there, we can basically locate the foramen of Monro, which is found basically by following the choroidal plexus and the thalamus vein, the both of which are actually going to be converging anteriorly at this point. And then we can actually dilate or expand the foramen of Monro and gain access into the cavity of the third ventricle. So there are actually 3 methods via which we can expand the foramen of Monro and gain access into the cavity of the third ventricle. So we can either incise or split the ipsilateral columns of the fornix, as we discussed that the columns of the fornix form the superior margin or superior anterior margin of the foramen of Monro, or we can actually just split the fibers in the line of the fibers, the line fornicial fibers, which is called as the interfornicial approach, or we can use the natural corridor, which is your transchoroidal approach, that is utilizing the choroidal fissure, which is present between the in the choroidal fissure, in which the choroid plexus is actually present, and the fissure is located between the fornix and the superior margin, anterior superior margin of the thalamus. So these are the three maneuvers or the three methods via which we can actually expand the foramen of Monro and basically gain access into the cavity of the third ventricle, which we can see here. Again, so this is a transforaminal approach, like we discussed, that this is particularly useful, and it for the tumors that are actually dilating the foramen, like we know the colloid cyst, and it's also get with significant morbidity because it results in memory impairment. Like we all know that the fornix actually houses the memory, so it's not really recommended as a preferred route. The choroid plexus is, like we discussed earlier, that it's going to be followed all the way anterior to the level of foramen of Monro, where it is converging, and then we can basically expand it in this manner. The choroid plexus is actually cauterized to minimize the chances of bleeding, and at the end of the procedure, we can also uh, open the septum pellucidum, which is basically the thin layer present between the two lateral ventricles, in order to prevent the univentricular hydrocephalus. Interfornicial approach, like we discussed, it can gain access by splitting the fornixes in the sagittal plane along the direction of the fibers. And in this particular approach, we know that the septum pellucidum is open and it can be used as a guide through the midline. And since the fibers are just split apart, so we know that we are causing minimal damage to them. But and the advantage of this approach is basically that we gain access to the midline cavity of the third ventricle, and we can approach the lesions that are actually present as just in the midline, and it's a wider axis. Consequently, the interferential approach is actually considered best for the patients who have a cavum septum pellucidum. So what's a cavum septum pellucidum? Cavum septum pellucidum, like we know that there's a cave present inside the septum pellucidum. So between the two leaflets of the septum pellucidum, there is a cavity, which is basically CSF filled. So it does not house how to identify where we're inside. So basically, there won't be any intraventricular structures present in that cavity. So we should know that if we're inside, so this is cavum and septum pellucidum. It's not present in all the cases. Like when it's transchoroidal. So the transchoroidal approach is basically via the choroidal fissure, like we discussed. It's a natural corridor which is located between the fornix and the thalamus, and the choroidal fissure is open, allowing the fornix to be pushed to the opposite side. In order to expose the structures that are present in the roof of the third ventricle, we would be gaining access to the space, which is the venium interpositum, and subsequently into the cavity of the third ventricle. So the choroidal fissure is actually the thinnest site in the wall of the lateral ventricle, which borders the roof of the third ventricle. So this was our transcallosal approach in the anterior region. Then we have the transcortical approach. So in the alternative to the transcallosal approach, we have an transcortical approach. And in this, the craniotomy is basically designed that it's 3 centimeters from the midline and 2 centimeters in front of the coronal suture. Again, the patient is positioned in the similar manner as we've done in the anterior transcallosal approach. So with the head lying in the supine position, the head is rotated slightly. The head is rotated slightly to the side that is opposite the frontal lobe, through which the ventricle is to be approached. The scalp and the bone flaps are actually positioned over the central part of the middle frontal gyrus of the non-dominant hemisphere. We don't utilize the dominant hemisphere unless and until there's a significant extension of the tumor into the lateral ventricle of that side, because we know that if you're actually accessing via the middle frontal gyrus, so we might actually damage, and the dominant hemisphere actually houses the speech area. So care should be taken if the approach is through the dominant hemisphere to place the cortical incision above and interior to the expressive speech centers on the inferior frontal gyrus and anterior to the precentral motor strip. So basically this picture, we can see that the craniotomy is unilateral. It is housing over the middle frontal gyrus, now frontal craniotomy. 3 centimeters lateral and 2 centimeters anterior to the coronal suture. And in the similar manner, we would be basically giving a transcortical incision. And if we're on the dominant side, we should be careful to remain slightly anterior to the precentral motor strip, as well as slightly superior so as to avoid damage to the inferior frontal gyrus, which houses the speech area. And then similarly, we can see here that in this inset that we are going to be utilizing the transchoroidal plane. The thalamus is actually retracted on one side, and we can see the fornix is retracted on the other side. This is the roof of the third ventricle, which is housing the vascular structures and the choroid plexus. And here, this is how we can gain access to the cavity of the third ventricle via the transcortical approach. Since we're going through the cortex, so that is why it is called as a transcortical approach. Then we have the subfrontal approach. So subfrontal approach again provides us 4 different corridors. We have a subchiasmatic corridor, which is basically located between the optic nerve and the optic chiasm. Then we have an opticocarotid corridor, which is through the triangular space, which is bordered by the optic nerve medially, the carotid artery laterally, and the ACA posteriorly by the lamina terminalis then, which is actually located above the optic chiasm, actually splitting up the lamina terminalis and then gaining access to via the anterior aspect into the third ventricle, and via the transsphenoidal approach that requires removal of the tuberculum sellae, the planum sphenoidale, and the anterior wall of the sella turcica. So here we can actually appreciate the opticocarotid triangle. This is your optic nerve, which is lying medially. This is your carotid, which is lying laterally. And inferiorly, we have the anterior cerebral artery. This is your frontal lobe, and this is your temporal lobe. So basically, this is through the Transsylvian approach via Pterional craniotomy. The true subfrontal approach usually requires removal of one orbital roof, and it can be advantageous when there is a large extension of the nasal into the third ventricle. However, a large extension into the third ventricle can also be removed through a standard pterional craniotomy by going with vigorous internal decompression of the tumor, often in combination with an incision in the lamina terminalis posterior to the optic chiasm. But with the pterional craniotomy, we know that the expanded opticocarotid triangle can be used for the surgeon's advantage. Sectioning the lamina terminalis, however, during the pterional approach is slightly difficult than is expected, because the posterior margin of the chiasm cannot be appreciated that well. So in this case, it is best to perform an aggressive internal debulking of the tumor through the opticocarotid triangle and to collapse the cavity of the third ventricle and to collapse the third ventricular extension of the tumor down into the subchiasmatic system. And then we can access from there. Occasionally, the infundibulum can be preserved, especially if the craniopharyngioma is a cystic lesion and it's largely cystic, so we can preserve the infundibulum which is present in the floor of the third ventricle. However, if the tumor is more calcified, so then fundibulum obviously it enters into the tumor capsule and cannot be separated and cannot be preserved. So patient positioning in this particular craniotomy is basically that the patient's head is slightly extended to decrease the need for the frontal lobe retraction. And despite the head being slightly extended, the chest is still angled slightly superior to promote the venous drainage. Patient is positioned with a Hayfield head holder, and the body and the trunk are actually elevated slightly to facilitate the venous backflow. The head is placed in neutral position in cases of bilateral approach, and sometimes it can be turned to slightly opposite side if you're going for a unilateral approach, that is a slight lateral shift to 15 to 20 degrees. Neck is slightly extended around 20 degrees to facilitate further relaxation of the brain after the dural opening. So this is the coronal incision. There's a bicoronal flap if you're going for the bilateral craniotomy. Then the skin incision, we have 2 skin incisions. If you're going for a bilateral craniotomy, we are going to mark a bicoronal skin incision. So this incision actually starts 1 centimeter anterior to the ipsilateral tragus, just above the zygoma. It's going to force along to the contralateral side behind the hairline over the coronal suture, and it's going to end again on the contralateral side 1 centimeter anterior to the tragus. Then frontotemporal incision, basically the incision is again going to be starting 1 centimeter anterior to the ipsilateral tragus, just above the zygoma, and it's going to force behind the hairline, reaching the coronal suture, and then it's going to go towards the contralateral side, just 2 centimeters beyond the midline, and the ending point is obviously going to be termed as 2 centimeters beyond the midline on the contralateral side, just behind the hairline. So this would be your unilateral frontotemporal skin incision, which is also called as a pterional craniotomy incision. So subfrontal approach for craniopharyngioma. A subfrontal approach for the resection of a craniopharyngioma is actually useful when we have a large extension of the tumor into the cavity of the third ventricle. So in comparison with the standard pterional craniotomy, we can also utilize the subfrontal approach with removal of the orbital rim and providing a better angle for the access to the anterior or the rostral portion of the tumor. Removing the orbital ridge is obviously going to require further time for performing the craniotomy, but again, it provides good access, so it's worthwhile performing that. Now, here are the three incisions that we can use for the subfrontal approach, like we discussed. So there are three bone flaps that we can use. The standard frontal craniotomy, which is very easy, just utilizing unilateral frontal craniotomy on the level of the coronal suture, going all the way till the ridge of just stopping above the superior orbital ridge. Then the second one is we're also involving the superior orbital ridge unilaterally to increase and enhance our exposure and further decreasing the need for the frontal brain retraction. And in massive tumors where we require bilateral access, so we have lateral extensions as well, so we can actually remove both the orbital ridges, and that can be advantageous. So both frontal lobes are retracted to provide excellent exposure for not only the rostral portion but also the lateral extensions of the tumor. So the craniotomy is actually achieved in the manner in via two bone flaps. So a standard frontal bone first a standard frontal craniotomy is done, and then in the second step we are going to be removing the superior orbital ridge along the superior sagittal sinus, and the outlines of the orbital removal are actually marked here in the dotted lines that you can see. So the craniotomy landmarks. So we have the first burr hole is made at the keyhole of the ipsilateral side. Then the second one is placed slightly 4 to 5 centimeters posterior to the keyhole, just below the superior temporal line for cosmetic reasons. And then the third one is actually made either 1 centimeters lateral to the midline in case of a paramedian frontal unilateral craniotomy, or over the superior sagittal sinus in cases of a midline frontal craniotomy. Posterior extension of the frontal craniotomy has to be tailored according to the pathology that is involved. Craniotomy landmarks, we know anteriorly it's the ipsilateral orbital rim. Laterally, it's the ipsilateral superior temporal line. Medially, there's anterior aspect of the sagittal suture, and posteriorly, there's ipsilateral coronal suture. So these are the bony landmarks that we can see here. The two burr holes, the coronal suture, the burr hole that is the posterior burr hole that is active coronal suture, then the superior, the anterior most, which is basically just above the superior ridge, and then the superior temporal line. So basically, this is your basic frontal craniotomy that we go for. And then if we want to enhance our access, then we can also involve the superior orbital ridge, and then we basically enhance the exposure further on. So it is important to preserve the supraorbital nerve. Often the supraorbital foramen is a notch, and a small spatula can be used to dissect the nerve out of its foramen and preserve it with the skin flap. Occasionally, the inferior rim of the foramen must be removed with a small ronger. The dura, the temporalis muscle, and the orbital fascia are actually dissected off with the bone and with a curved periosteal elevator and a Penfield 1:1 dissector, like we can see here. So basically, we're putting a spatula in order to prevent damage to the supraorbital nerve here. Next, the dura is actually opened and it is folded over the orbit and it's retracted with the help of a head suture so that we can go for our procedure further on. Then the right frontal lobe is actually lined with hemostatic fabric and cottonoids and gently retracted upwards. And the amount of retraction obviously required is minimal because of the removal of the orbital ridge, which has already provided us greater access. If more bone
Dr. Afifa, your voice is breaking in the middle, so kindly speak up.
Okay. If more brain retraction is necessary for larger tumors, then the cisterns that are present around the optic nerve, the subchiasmatic cistern and the optic cistern or the optic recess we have, so we can drain those cisterns and the internal carotid arteries. They can be incised so as to promote the drainage of the cerebrospinal fluid, and so we have to go for minimal retraction of the brain tissue. With this approach, the lamina terminalis is incised, and the lamina terminalis usually is extremely thin and merges almost imperceptibly with the capsule of the tumor interiorly. After the lamina terminalis has been incised and the tumor capsule has been entered, the tumor is decompressed internally and it's debulked with ringed curettes. When incising the lamina terminalis, it's best to leave 3 to 4 mm of tissue behind the visually identified posterior margin of the chiasm in order to prevent any kind of damage. After the tumor has been debulked, the capsule is manipulated with a cottonoid or on a suction tip, and then fine spatulas or bipolar cautery forceps are used to peel the capsule gently off the optic tracts and optic chiasm. It's also important to recognize that deep to the tumor is basically lying a layer of arachnoid that overlies the basal artery and its branches, and laterally this arachnoid overlies the posterior communicating artery. So preserving the arachnoid will actually help us prevent damage to these vital structures. So after the tumor has been removed, the margins are inspected, and we don't need to cauterize any bleeding from the walls of the third ventricle, because at this point we're actually the walls are the hypothalamus, the margins of the hypothalamus interiorly. So instead we use irrigation and small pieces of hemostatic materials to actually achieve hemostasis. And after the resection has been completed, the retractors are withdrawn and the frontal lobe is inspected again for any kind of contusion. The dura mater is closed primarily or with periosteum, and the bone flap is repositioned with metal plates. Next, we have the posterior transcortical approach. So in this approach, this is again directed through a cortical incision in the superior parietal lobule, and this exposes the interior of the atrium, which is the posterior part of the lateral ventricle and the posterior part of the body, and it may be the preferred approach for a lesion that is situated entirely within the atrium or arising from the choroid plexus, or a lesion that is involving the atrium and the posterior aspect of the third ventricle and the quadrigeminal cistern, which is basically lying in the posterior aspect of the third ventricle. So the patient is positioned three-quarter prone with the face turned towards the floor so as to place the parietal area to be operated superiormost, and a high posterior parietal bone flap is removed behind the postcentral gyrus over the superior parietal lobule. The cortex is actually incised in the long axis of the superior parietal lobule in the region behind the postcentral gyrus, preferably in the sulcus crossing the lobule, and this cortical incision actually avoids damage to the visual pathways that are traversing in the parietal lobule and the speech areas that are present at the junction of the parietal and the temporal lobes. Then we have the posterior transcallosal approach. So this approach is again best suited to lesions that are extending upwards from the atrium or the third ventricle through the posterior part of the splenium, or the ones that are arising in the splenium and extend into the atrium and the third ventricle. The surgery is commonly performed in the three-quarter prone position, with the parietal region to be operated uppermost, and a better alternative with some lesions is to actually place the side of the approach downwards, so the medial surface of the hemisphere will fall away from the box, and it can provide you good access and thus reducing the need for retraction. The parieto-occipital scalp flap and the craniotomy can extend to or across the superior sagittal sinus and can have the anterior margin behind the post-central gyrus and the vein. Then we have the lateral frontal approach. So this approach is again utilized and it's useful for the midline suprasellar lesions and anterior third ventricular lesions. Position is supine. A bicoronal incision is made. Craniotomy starts laterally at the level of the pterion and it runs just above the supraorbital ridge. Resection is basically achieved by the prechiasmatic space that is anterior to the chiasm, the opticocarotid triangle, like we discussed on earlier, which is bounded medially by the optic nerve, laterally by the carotid, and inferiorly by the anterior cerebral arteries. So we can gain access via this, or we can gain access via the prechiasmatic space that is anterior to the chiasm, or the retrocarotid space that is basically lying posterior to the carotid. Then we have the Pterional approach. So this is again a common approach to the suprasellar tumors that are extending into the interior of the third ventricle. And the positioning is again supine with the head tilted approximately 45 degrees to the left and approximately 20 degrees of extension. The incision obviously follows the hairline all the way curved from the zygoma anterior to the air in the frontal region, like we can see here. This is the craniotomy flap. The tumor is accessed again through the retrocarotid space, like we discussed, and the opticocarotid triangle or the prechiasmatic space. Then we have infratentorial supracerebellar approach. So this is again well suited for the midline tumors present in the posterior aspect or in the pineal region and avoids retraction or manipulation of the cerebral hemispheres. The patient can be placed either in the sitting position or the three-quarter prone position, and the incision is midline, and a wide suboccipital craniotomy is performed so as to while exposing the transverse sinus naturally and the torculum, where which is considered as the confluence of the sinuses. Then we have the occipital supratentorial or transtentorial approach, which is utilized for pineal and posterior third ventricular lesions with either supratentorial or infratentorial components. The position is sitting or semi-prone, like we discussed earlier. The bone flap extends up to or across the margins of the transverse and the sagittal sinuses. The dura is open with pedicles on two sides, that's the transverse sinus and the sagittal sinus. And the right occipital lobe is retracted to allow settlement downwards away from the fox in order to expose the isthmus of the cingulate. And an internal occipital vein can often be sacrificed during reaching this area. Here we can see that the occipital craniotomy is basically this way. So this inferiorly we have the transverse sinus, this is your sagittal sinus, this is the confluence, and this is how we can gain access here. The occipital lobe is retracted, and we can be this is your tent that we can appreciate. The dura is actually elevated in the manner of two leaflets over the transverse as well as the sagittal sinus, and we can gain access into the posterior aspect of the third ventricle. These are the venous structures. This is your internal cerebral vein that we can see. Then we have endoscopic approaches. Endoscopic approaches are also useful for intraventricular tumor surgery, and the most commonly treated lesions using endoscopic approach are the colloid cysts of the third ventricle. The limitations of endoscopic techniques, however, prohibit the removal of tumors with high vascularity or fibrous consistency. So here we can see a solid lens endoscopic sheath integrated with an infrared navigational tracking device, and this is being registered. Here we can see the endoscopic pathway that is superimposed on a preoperative MRI in selecting the ideal trajectory for the third ventricular tumor, and the dimensions of the endoscope is depicted so as to simulate the true size of the scope. Then endoscopic tumor procedures include endoscopic fenestration, then tumor biopsy, simultaneous tumor biopsy and endoscopic third ventriculostomy, solid tumor resection, and colloid cyst extirpation. So septal fenestration is basically, and tumor fenestration are the two simplest of the endoscopic procedures, owing the relative avascular nature of these membranes. Fenestration of the septum pellucidum should be considered in any patient in which a tumor mass is situated in the anterior third ventricle or within the lateral ventricle at the foramen of Monro, resulting in compartmentalized hydrocephalus. Endoscopic fenestration of the septum pellucidum generally is performed by an entry site that lies more lateral, at least like around 4 centimeters from the mid-sagittal plane than the conventional coronal burr hole. It is recommended that the site of the septal fenestration to be positioned between the larger tributaries of the septal veins and as superior as possible from the fornix in order to avoid damage. Generous fenestrations are made with cautery, and confirmation of effective communication is established with identification of contralateral ventricular landmarks, including the choroidal plexus and the ependymal veins. Surgical technique. Because of variability in each patient's anatomy, surgical planning is critical in optimizing the surgical goal and reducing the potential morbidity. Integrated stereotactic navigation is always used for surgical planning and optimizing the ventricular cannulation. Laterality should be determined based on preoperative MRI, with emphasis on the relative size of the frontal horns of the lateral ventricle and the dimensions of the foramen of Monro. Because the intent is basically to work below the ipsilateral columns of the fornix, and an entry site is used that is far forward of the coronal suture. In a sagittal dimension, the ideal trajectory passes just above the floor of the anterior horn through the foramen of Monro and below the roof of the third ventricle. So basically, this is an MRI where we can see lesions present in the third ventricle anteriorly. In an axial and coronal plane, a trajectory is selected that passes between the head of the caudate and the column of the fornix into the foramen of Monro. The entry site that is selected with stereotactic guidance is marked on the skin surface prior to the surgical prep, and regardless of the entry site, a curvy linear incision is planned on the hairline with a variable length depending upon the interior location of the planned burr hole. Once the frontal horn of the lateral ventricle is entered, the anatomical landmarks of the frontal horn are identified. Using a 30-degree angle lens, the endoscope is then rotated to offer a superiorly directed view towards the roof of the third ventricle. The site of the attachment of the colloid cyst is identified. The endoscope is then navigated towards the foramen, where typically the wall of the colloid cyst is in clear sight, obstructing the foramen, and generous bipolar coagulation of the choroid plexus is used to gain better visualization of the lateral cyst surface. Bipolar forceps are utilized to bluntly dissect the cyst wall away from the walls of the third ventricle. This coagulation device without current is used to push the cyst wall away from the ependymal surfaces. When sufficient space exists between the cysts and the walls of the third ventricle, power is then switched on to coagulate the cyst surface. Perforation of the cyst wall by either sharp dissection or electrocautery is utilized, followed by aspiration of the contents, and a graduated 6 French endotracheal suction catheter that has had the distal fenestrations removed is preferred. The clear cannula allows direct visualization of the contents that are being suctioned. This is very helpful in gauging the strength of the suction applied and in discontinuing aspiration of if choroid plexus gets inadvertently aspirated. It is critical that aspiration only be applied once the tip of the device is placed within the cyst wall, thus avoiding the rapid evacuation of CSF from the ventricular compartment, and utilizing the suction aspiration, the contents of the cyst can usually fully evacuated. The viscosity of some contents may require repeated clearing of the cannula due to frequent clogging. With partial evacuation of the cyst can commonly be drawn into the foramen with grasping forceps, and this maneuver positions the lesions for continued aspiration and further coagulation. The superior aspect of the cyst can be dissected away from the roof of the third ventricle by using a rotary motion with grasping forceps, in effect pulling the cyst in an inferior direction towards the floor. And when visualized, the adherent portions of the forehead plexus should be coagulated and sharply divided. Here we can see the scope that is placed via a single burr hole. We are gaining access into the third ventricular cavity. These are the vital structures that we discussed on earlier, all the anatomical relationships. This is the interiormost area, the tuber cinereum, the floor where we make the endoscopic third ventriculostomy burr hole. This is the endoscopic view. We can see the choroid plexus here, this one, the lateral structure, the vein that we were discussing, that's your thalamostriate vein. This is your septum pellucidum. This is your septal vein that is present. This is the foramen of Monro. Like we said, the thalamostriate vein actually curves around the posterior margin of the foramen of Monro, and it lies far lateral. It helps in localizing the side of the ventricle as well. Similar picture here. Again, we can see here from anterior to posterior. This is the optic chiasm. This is the endoscopic view that we can see. Then we have the infundibulum. We have this is the floor or the clivus of the third ventricular. Then there are two rounded body structures which are present in the floor of the third ventricle, the medullary bodies and the basilar tip that we can appreciate here. So while doing an endoscopic third ventriculostomy, we have to remain interiorly, and we basically make a hole in anterior to the medullary bodies at the level of tuber cinereum. Okay, so the typical appearance of the right foramen of Monro as visualized through an endoscope, as we discussed here, this is the foramen of Monro. This is your choroidal plexus, and this usually the foramen is actually enlarged because the fornix is being stretched, and the typical interventricular landmarks that are visualized include the medial septal vein, the choroid plexus, the far lateral thalamostriate vein, the lateral anterior caudate vein, and it's important that we do not traumatize the fornix as the endoscope is being passed through the foramen, and most of the endoscopes have a side port that can be used and utilized for irrigation, and irrigating through the scope as it is inserted through the foramen will gently push the fornix out of harm's way. Then, as the scope is further inserted through the foramen, the memory bodies become more and more prominent and visible. The point of puncture is interior to the memory bodies in the region of tuber cinereum, like we discussed. And looking through the scope interiorly, we have the dorsum cellae and the clivus. And if the tuber cinereum is thin, the outline of either the basilar or the posterior cerebral artery can be seen in the posterior aspect. There are several techniques for puncturing the tuber cinereum. The endoscope itself can be utilized as well in some cases. More sophisticated scopes have a side port that allows the passage of a dilating balloon to enlarge the third ventricle. Often there's slight bleeding, which will stop further on with irrigation. Then the endoscope can be inserted deeper to better visualize the basilar artery. Usually there are strands of arachnoid present between the clivus and the basilar artery, and the surgeon should not attempt to cut it or lyse them with arachnoid and lyse these arachnoid trabeculations. So yes, I'm done. Thank you.
Thank you, Dr. Afifa, for a detailed presentation. I would like to request now Professor Chandrashekar if he can share his views and maybe a case if possible as well.
I'm just wondering, do you have enough time?
So we have 5 minutes, I think.
Okay, I'll try and do a quick job. She has explained most of the approaches.
Dr. Afifa, can you stop screen sharing?
I've already stopped screen sharing.
Thank you.
There is some issue. I am still seeing her screen.
Afifa, can you check?
I will just get out of Zoom and I'll probably.
Now you can screen share. I've allowed it.
Professor Deopujari, can you try again, sir? I think he went offline. Maybe he's trying to connect again.
While Professor Deopujari is reconnecting, do we have any questions?
Guys, if you have any question from Dr. Afifa or us, you can use the chat box. I know today has been a little bumpy. We'll try and fix this next week. So he's rejoined. So guys, if you guys have any questions, we'll be happy to answer. Next week, we'll be presenting fourth ventricle. And this time, I think it will be not one of our resident presenting, it will be somebody else.
Can you hear me?
Yes, sir, we can hear you.
Okay, I'm terribly sorry. Something did go wrong that I could not join you. Can you see my screen?
Yes, sir, it's coming up right now.
Okay. So basically, I would not take you through the whole we went through the lateral ventricle the last time, and I would just like to talk about a few things which were discussed now. And let us start with a case of a purely intracranial, intraventricular kind of a craniopharyngioma. So this boy mainly presented with papilledema and signs of raised ICP, which is very classical of intraventricular tumors. You don't get a field defect. And lamina terminalis is the approach which we chose, as was just discussed. So best is to, this is a interhemispheric approach. You have seen that there is very little space here. So we have opened into the lamina terminalis, and we are using a railroad method to take the tumor out from the third ventricle, as well as a little bit of tumor which is protruding into the suprasellar region. And you can actually use this approach in a manner that you can decompress the tumor, and you can do railroading to see if you, as more and more tumor comes out, you can get the pre optic space a little better, and you can probably remove some of the tumor from over there. This is the calcified part of the tumor which is coming out, and you can see that the basilar artery tip is seen, as you saw during the third ventriculostomy picture. There, here the Liaquat membrane is also gone, so you can see the artery well. This is another tumor which has been removed by the lamina terminalis approach. Now the other approach, when you have the tumor again which is not going into the suprasellar portion at all, is to go through the foramen of Monro. And this is a classic case where the tumor is being tackled through the foramen of Monro. You can see the arch of the fornix here, and you can see the tumor, the cyst is being drained, and as once the tumor is decompressed, more and more tumor is coming out. I won't take too much of time. You can see that the wall of the cyst is getting gradually separated, and this kind of an approach is ideal to decompress the cyst or radically remove a tumor if it is completely intraventricular, like in this particular patient. You can see the floor of the third ventricle below that. So that's another approach. Now we were talking about transcortical approaches. The main problems with transcortical approaches, the seizure incidence is probably higher, though the literature missed about it, because even transcallosal approach can cause seizures. Though the percentage was thought to be less, more and more papers are coming out that probably there is not much of a difference. The other thing is, depending on the eloquence of the cortex, anteriorly or posteriorly, you can get either hemiparesis or hemianopia. And subdural effusions, if the track is not closed properly, can be a problem. And depending on which area you approach it from, you can get several kinds of problems, which is well recognized. While in interhemispheric transcallosal, the main worry is that you should not go beyond 10 to 15 millimeters when you are actually doing the opening into the corpus callosum. And then there is lower risk of motor, sensory, visual disturbance. The cognitive disturbance, some people have said, is probably higher, and injury to the veins can be higher. So this is a typical example. This is a subependymoma, and you can get this kind of a tumor which is lying around the foramen of Monro very well by a transcallosal approach. This is another patient where we have been able to remove this approach. This is a interhemispheric transcallosal approach. You can see that the callosum is being exposed, an incision is being made, and then you are onto the tumor. And this is towards the end of the tumor removal, where we have been able to clear the tumor almost completely. And then you are looking at the third ventricular floor, like what you see at the third ventriculostomy. One of the important problems we talked about is the subdural hematoma. This is another patient with a transcallosal kind of excision, and the third ventricular tumor is ideal for this kind of a lesion. Now, in the follow-up, you can see that the whole tumor has been excised. This is another subependymoma which has been excised. This is a pilocytic astrocytoma. Let's get to tuberous sclerosis, where again, this is an ideal kind of an approach where you can remove it by the transcallosal approach. Even a large tumor can be removed once you start debulking it. Germinoma, this has been mainly used for biopsy. And the colloid cyst is the most important consideration. Earlier, we used to use transcallosal approach for most of these tumors. And today, you know which patients to operate by this colloid cyst risk score. This is something I would like all of you to read up. And the fact that you can do an endoscopic approach, this is a transcortical approach. Transcortical approach takes you directly to the cyst, and then you can enlarge the foramen of Monro and take this cyst out once you have drained it out. I think this has been very adequately discussed. And this is the endoscopic kind of an approach where you first burn the pedicle of the choroid plexus supplying the tumor or adherent to the tumor. Make sure that you do not damage the veins around it and remove this completely. You must be aware that if there is a posteriorly placed cyst, you cannot do it, and you need to apply the transchoroidal approach for this. And we have written an article on the position of the fornix and the lesion, and when the transchoroidal approach becomes significant in these kind of a patients, and the very rare possibility of doing an interfornicial approach, which is being abandoned as time passes. We just talked about endoscopic approaches, which are good for cystic lesions. And for a posterior third ventricular tumor, the endoscopic approach is ideal. You can take a biopsy, and occasionally you can even remove the cyst. And it has now become virtually a kind of algorithm that if you have hydrocephalus, you would always use endoscopic approach, create a CSF diversion by septostomy or a third ventriculostomy, take a biopsy, and then decide about the definitive management. I will stop here. Thank you.
Thank you, Professor Deopujari, for your presentation and excellent cases. If there's any question from the participant, we'll be happy to take it. We are right at the end of our session. I again want to thank Professor Deopujari, who was present there last week, and he's present here today. I mean, it shows his dedications towards education. Thank you, sir, for your presence.
Most welcome.
And if there are no more questions, I think we are already late. We'd like to end this session. So Dr. Maroof has left a message in the chat box. If you guys want to have more, you guys can share your WhatsApp number with him. Dr. Maroof, can you share your number there so they can share their information? Next week, we'll be presenting fourth ventricle. We'll see you next week. Thank you for the session. Thank you, Professor Deopujari, again.
Thanks, and I would like to have more interaction next time. Rather than presenting, I would be happy to take questions.
So, definitely, sir. Definitely.
Again, next week I cannot join, but later on, let me know if any
sir,
topic.
We will bug you. We will bug you the week after that, sir. Thank you, sir. And guys, you can share your number with Dr. Maroof has posted his number. You can share your WhatsApp number with him for more lectures related to neurosurgery. Thank you all. We'll see you next week when we'll discuss fourth ventricular surgical approaches. Thank you.